Great, we've got the recording going. So welcome everyone to the 2017 FluFIT Flu iFOBT Summer School webinar series. My name is Jill Ireland with the American Cancer Society, and I'm pleased to moderate today's call with my colleague, Stacey Burnett. This is the first of 3 webinars throughout the summer. The series will focus on FluFIT, a program refresh and overview. The organizers plan this series as a FluFIT 2.0 version. So if this is your first introduction to the FluFIT program, today's webinar will provide an understanding of the program components. Or if you're relaunching your FluFIT campaign, there will be content to support your planning and implementation. The webinar series is presented by the American Cancer Society in partnership with Great Plains Quality Innovation Network, South Dakota Department of Health, Great Plains Tribal Chairman's Health Board, the South Dakota Comprehensive Cancer Control Program, the Community Healthcare Association of the Dakotas, and North Dakota Department of Health and Kansas Cancer Partnership. As a reminder, please feel free to add your questions to the chat box throughout the presentation. The speakers will address any questions at the end of the presentation. So just wanted to quickly review our agenda. We're going to start with a FluFIT program overview. We have Dr. Michael Potter, and we have 2 field examples from Mallory Cosell, Director of Quality from Sanford-Fargo region, and Jackie Arpan, Public Health Educator, and Brenda Mills, Community Health Nurse from Indian Health Services, Doosan Hospital, and then we'll wrap up with questions. Just to review our learning objectives today, we'll explain the value of FluFIT, iFOBT as an evidence-based intervention to increase access to colorectal cancer screening, and understand the key planning steps and protocols to determine patient eligibility, and also describe some resources in your program planning materials available to support your implementation. So at this time, I'm pleased to introduce today's featured speaker. We have Michael Potter, the Professor of Clinical, Family, and Community Medicine at the University of California, San Francisco, and a member of the Helen Diller Comprehensive Cancer Center at UCSF. He sees patients and teaches medical students at UCSF Medical School and at San Francisco General Hospital. Dr. Potter is Director of the San Francisco Bay Area Collaborative Research Network, a primary care practice-based research partnership between community-based clinicians, practices, and UCSF. Dr. Potter's research focuses on innovation and practical approaches to promote cancer screenings in diverse healthcare settings, especially in communities where access to cancer screening has traditionally been limited and where disparities in cancer screening rates persist. Dr. Potter is an individual member of the National Colorectal Cancer Roundtable and has served on several of its subcommittees before joining the Roundtable Steering Committee in 2008. Dr. Potter, it's a pleasure to have you on. I'll turn the presentation over to you.
Well, thanks for that nice introduction, and I am really excited to be able to offer some help or information that might be helpful to your sites in the Great Plains region. Why don't we go on to the next slide? So I'm going to talk for about 20 minutes about fecal immunochemical testing, what are the characteristics of a high-quality FIT program. That's really what our goal is here. And then as an example of that, talk about the FluFIT program and its components and some implementation examples and some resources, and I think you're going to hear about some other experiences from your colleagues after I speak. So let's go on to the next slide. So I don't know that I really need to go over this with you all because I know that everyone on the line is really interested in colorectal cancer screening, and you're working in many of you, most of you are working in community health centers where fecal immunochemical testing is probably your first choice, but it is reasons for using it as your as a primary screening modality is that it's inexpensive, it's easily obtainable, It doesn't require any special expertise to offer it. It can be offered, anyone on your healthcare team can be trained to offer it, to assess patients and offer it to patients when appropriate. It can be done by the patient. It doesn't require them to go to any special location. It can be done by the patient in privacy at their own home, often with just a single stool specimen and without any special preparation, meaning you can give it to the patient and tell them, please do the sample tonight and mail it tomorrow. And that really makes it extremely easy to use. It's non-invasive. It has no risk of pain, bleeding, bowel perforation, or other adverse outcomes. You can't hurt yourself by doing a FIT test. It only requires a colonoscopy if abnormal, and we know many of our patients are reluctant to make the jump to go to colonoscopy, and many of our systems only have limited colonoscopies to offer, so it allows you to be prudent about who you offer the colonoscopy to the people who are most likely to benefit. If the stool testing is done yearly and followed up correctly when abnormal, there's also plenty of evidence to say that it is similarly effective to colonoscopy in terms of preventing colorectal cancer death. And then finally, many patients actually prefer to do annual stool testing to doing a colonoscopy. So those are the reasons, those are the advantages of it. It's not to say that this is the best test for everyone, but those are the advantages, and there's a lot of them, and they're very strong. So we should all be enthusiastically advising patients that this is one of the primary outstanding options to do colorectal cancer screening. The next slide, please. So, and as I don't have to tell you, FIT is especially important in public health settings where colonoscopy access is limited. This is 2012 data for federally qualified health centers and lookalikes from the UDS data from 2012. And you can see in the Great Plains states, the screening rates are, and all across the country, the screening rates in 2012 were very low. And actually, I think because of the reporting requirements and because of a lot of the efforts of a lot of you and a lot of others, screening rates are increasing. Next slide. And you can see, just for example, for all FQHCs, the average has gone from 30% in 2012 now to 38% in 2015. And some of the selected states, you can see there have been improvements. Still a lot of way to go. And it's clear that this is, of course, 2015, and now it's 2017. It's clear that many of you are continuing to make improvements. But I think we all still agree that even if we're getting over 50% in these settings, we still want to get to 80% at least. And so we have a lot of work to do. But lots to congratulate ourselves for, and lots to inspire us to continue the hard work and move forward. Next slide, please. So it is an easy test, FIT testing is, but to do it as a program and to get all of your patients in a health center to be screened or to offer it to everyone and follow through, it does take a lot of work. And that should not be minimized. You have to pick first of all, you have to pick which brand of kit you're going to use. You want to use one that has some evidence behind it. And there's guidance from the National Colorectal Cancer Roundtable, for example, on which tests are best. They're all relatively inexpensive, so no one should be using a substandard test. Some of the kits on the market, however, are not as well tested and they're on the market and FDA approved, but they may or may not be as effective as others. So that's an important first thing that any program should do. You should know what test you're using and what the evidence behind that particular test is before you start using it. You need to identify your eligible patients. You need to be able to have either when they come into the clinic or even better, if you have a registry of your patients in the 50 to 75 age group, you can tell whether they've had screening. You can develop an outreach program. You have to train your staff to communicate with patients about colorectal cancer screening, all those things about why the test is a good test, why it's effective, why it needs to be done every year. A lot of times staff are hesitant, reluctant to ask a patient to collect their stool because they don't feel it's a very pleasant thing to do, or because they don't understand why it's really important. You really need to train your staff to be as enthusiastic as possible about this really great test that has a very good chance of reducing colorectal cancer in your community, and to remind people about things like that colorectal cancer screening is not just to find things early, but it also, if done regularly, can actually find things before they become cancers and prevent cancers. So we need to have everyone to have a very positive attitude towards colorectal cancer screening in the clinic. We need to provide appropriate test instructions. Some of these kits come with very complicated test instructions, high levels of English that even if you speak English, it may be hard for people to understand. We have to have instructions in multiple languages often in the FQHC. Sometimes if you can develop wordless instructions, that can be useful, or if you can develop a graphic or some sort of a chart to show people what it is like to complete a test if they've never done it before. These things make a difference. Then once you have provided the test to the patient, you have to assure that it's completed, and oftentimes people need reminders, and that might mean a phone call in 2 weeks, a postcard in 2 weeks, text message, whatever method you have. It's really important to give them the message that they should be doing it right away, and if they're not, they should be getting a little bit of tickler to remind them if you don't do that, you will not maximize your test completion rate. And then you have to assure that the test is processed appropriately. And that means your staff, if you're using a test that's operated in your clinic, you need to really be sure that your staff is well trained to do it, and that they know what a positive test is supposed to look like, and you should be following up on that periodically. When possible, if you can have it done in a way that it gets sent to a centralized lab, that's always, and that the reporting gets into your electronic health record easily, that's always a nice option, because then you can just have them mail the kit somewhere else and your clinic doesn't have to handle all these stool specimens. That often increases the enthusiasm of the staff when they realize that the stool is not coming back to the clinic and they're not going to have to actually handle the kit afterwards. So then you have to, if the test is abnormal, of course, that obligates you to get the patient a colonoscopy, and that's often not easy, and you should not be offering FIT programs in locations where you can't assure the patient can get a colonoscopy if it's abnormal. And patients need to really understand why it's important to get that colonoscopy. And even if you're making them wait for 3 or 4 months to get that colonoscopy, you need to help them understand why, if it's so important, why do I have to wait several months to get it? So you really need to follow up with people to completion there, and that can require some navigation. And then, of course, you have to do it all over again. If it's normal and they need another test in another year, you have to start the process all over again. So that any FIT program requires a lot of work for any clinic to get a high rate, and I think that's one of the reasons why our rates aren't higher. It just requires a fair bit of commitment. So next slide, please. So that's why, you really, before you start a program, you need to ask yourself, how important is colorectal cancer screening within my organization? Hopefully you all agree it is really important. But then who will lead the effort and what resources are available? And, are we willing actually to give someone the time to coordinate an effort in our clinic? Because you can't, if you're going to do something new, you have to commit. You have to put in the time to make it work, especially at the beginning. And then if you're doing other activities that are working well, for example, a flu shot campaign, which many clinics do extremely well from many years of practice, what can we leverage and learn from those activities? How do we make it easier for the patients? Like I said, as far as the the test instructions, or if they've done the test before and they know what it is, and maybe you can mail the kit to the patients, or maybe you can provide postage on the return envelope so that they don't have to come back to the clinic to drop it off. And what can we do to make it easy for clinicians and staff to do the right thing? What are the protocols they're going to put in place? And then if you make a campaign, obviously, as we said, it's something that you can't just do once. You have to do stuff you're going to have to do this year after year. So what are you going to commit to make this sustainable and scalable in your organization? So next slide, please. So why FluFIT program? So the FluFIT program is just simply especially useful for, I think, clinics that have not yet gotten all their systems going, maybe need a campaign to get everyone up to speed. It's a great way, and if you're in a clinic that is already doing flu shot activities every year, it's something you can combine. It creates an opportunity for the whole clinic to gear up for a time-limited campaign, because it can be really overwhelming to think about, well, now we're just going to do all those things that I just listed now and forevermore. Sometimes it can be really helpful to say, well, let's just try this campaign, and then you can get everyone on board and try something and learn from it. The lesson learned that you learn from a FluFIT campaign can be used year-round. And because it's a time-limited campaign and it's built into something that you're already doing, it's often feasible to start a FluFIT program with limited resources, and you can do it. Usually it can be sustainable without a lot of outside help. And it is adaptable for many different types of clinical settings, as you'll see. Next slide, please. So this is a diagram of the FluFIT program. These are the different steps. There's a planning and implementation phase. There's then there's a daily implementation. So you planned it, and then you need to actually do it. And then there's tracking of the kits after they've gone out. If it's not completed, you need to call them. If it's completed, you need to get them the results. And if it's abnormal, you need to get follow-up to colonoscopy, or you need to get follow-up for, remind them that they're going to have to do it again next year, and there's lots of steps here. So that's one of the reasons why, if you're going to do a FluFIT program, it does require some advanced training and planning, and that's why this is a great time to start thinking about it. And this is something that's available on our website, so you can look at this later. Next slide. So again, where to do it. These are just some examples of places where we've done research studies. We've done it at the upper left-hand corner is at San Francisco General Hospital's Family Medicine residency program, a large outpatient clinic that has a large annual flu shot clinic where people are scheduled to come in. In that setting, they have people, they know who's coming in, so they can look at their charts in advance, and they can see who's going to need the stool test, so they just get it all ready beforehand along with the flu shots. The flu shot team works to get everything ready, and they hand them out to people as they go through and explain it to them. On the right hand, there's a cluster of 4 primary care clinics in the San Francisco Public Health Department. We did it in many more than that. It's just pictures. Those are clinics where they don't have flu shot campaigns, where they have flu shot clinics, but they have a flu shot campaign whereby patients who come in for any type of visit during a certain period of time, they get their flu shot offered to them, and they've developed a system whereby if they're offering a flu shot to a patient, they're also checking to see whether they need a colon cancer screening test, and then they offer them a FIT test if they need it. The lower left-hand corner is Kaiser Permanente, which is a large HMO commercial in California. And there they do have these very large, long lines that, for flu shots every year, and they've developed a system whereby as the patient's card gets swiped and they get logged in for their flu shot, they can also see whether they're due for a colorectal cancer screening kit, and the person who's checking them in actually hands them a kit if they're due before they get their flu shot. Screen just went dark. Okay, there we go. And then we send some pilot testing at pharmacies. This is a Walgreens pharmacy near where I live. And in theory, this is a great potential place for providing colorectal cancer screening kits. However, there's a lot of logistical issues there because pharmacists have to be engaged, and that's a nut that you have to crack, and someone has to be, the primary care team has to be alerted if there's an abnormal test so that they can assure the patient gets colonoscopy. So this is that's something that in theory could work very well, and I think it is perhaps a wave of the future as pharmacies are offering more and more preventive services. But it is and I know people are working on this. I believe there's some folks in Kentucky and West Virginia actually who are trying this model, but it does require a different level of commitment and from different types of professionals. Next slide, please. So in theory, basically wherever people get flu shots is a place where you could offer colorectal cancer screening. This is one of those lines at Kaiser Permanente. When I first saw this, I saw these people waiting in line for colorectal cancer screening, many of them for flu shots, and many of them looked like they were between 50 and 75. And of course, when I saw that, it's like, look at all these people waiting in line. We have a great opportunity to get this captive audience screened for colorectal cancer. And the people at Kaiser really like the idea, and it has really taken hold in a number of their facilities. Next slide. And then this is just an example at Kaiser of how they do it. These are people registering for their flu shots, and the woman in the middle is actually handing someone a FIT kit. And you can see there are posters that they're putting up around the area to explain what they're doing so people aren't surprised. And the staff there are trained to answer a few questions about colorectal cancer screening, but they're not giving a huge amount of additional training and additional information. They're giving the patient the kit with some information, multilingual information inside of it. And it's one of many strategies that Kaiser uses to promote colorectal cancer screening. So this is a sort of a situation whereby they mail people FIT kits. They have people in primary care offices offering it when they come in. They have people in pharmacies when they come to pick up their pharmacies at the Kaiser, their medications at the Kaiser pharmacy, they're offering it. And then at the end of the year, when they have their big flu shot campaign, almost everyone already knows about the importance of FIT, and this is a chance for them to reach people who otherwise maybe haven't come in yet or need a little extra push to get their FIT tests doing. And many of the Kaisers in California now have gotten screening rates of close to 90%, and this is just one of the components of their program. So it's really, when we think it's not possible to do better than 50%, here's an example of a group that's getting us close to 90%, of course, with a lot more resources and energy than the staff and so forth, and investment probably than a lot of community health centers can make, but at least they're showing us that it's possible. And they're doing it not just by focusing on colonoscopy, but they're making FIT a major part of their push to get people screened. Next slide. So, and it's embedded in their system, and in fact, it's not only it's endorsed by their leadership. It's they have flu shot teams at the region. They are trained in the region, and they all learn about stool testing when they're training for their flu shots. And they come together and they get hands-on training. They have access to a webinar for people who are less experienced in doing this. And they even have an internal website that supplements our external website with specific materials. And the picture on the bottom is an example of their practice session where they're having people practice being patients, and they're practicing giving flu shots and FIT kits, offering FIT kits. And so they're getting to practice actually how they interact with each other and get feedback. So it's really quite amazing. Next slide, please. So here is a basic FIT algorithm. I mean, if you don't have point-of-care reminders or point-of-care access to whether a person's had colorectal cancer screening or not, you can simply, this is a very simple way to do it. You just check and see, are they in the age group? Have they had ask them if they've had a colonoscopy in the last 10 years. Most people know if they've had a colonoscopy. They may not know exactly 10 years, but they'll know if they've had one. They'll usually know if they've had one within 10 years. And they'll usually remember if they've done a stool test in the last year. And if they say no to if they're in that age group and they say no to being screened, at least you can offer them a FIT kit. And this can be modified. Some people, in some places, people are concerned. For example, if you have a family history of colon cancer, they want to make sure that they get referred to a colonoscopy. That can be really an important thing to do. Clearly, that's something in the primary care relationship. They should already be being assessed for that and already being referred. This is sort of a public health orientation of this intervention. You may or may not feel it necessary to ask all those other questions because you can at least make sure they're getting some kind of screening if you're in a population where most patients have not been screened. I think that it's okay to cast a wide blanket and just try to get as many people screened as possible. Next slide, please. And then this is an example of one of the posters. These are tailor-made things. We have these things on our website, and you can tailor them, but this is what we had in the Family Health Center, where we have 5 languages primarily spoken. And the messages that you give people are really simple, but, you know, if you're here for a flu shot, you know, that's preventable, flu's preventable, but colorectal cancer is also preventable. And it's easy to do, and it could save your life. And then the recommendation that everyone is on board and recommends it is good. And in this clinic, they were screening people 50 to 79, but I think the standard is now at least 50 to 75 that we think everyone should be screened. And it's a really simple message. And the posters can help the patients, but it also can help reinforce the messages for the staff. Next slide, please. See what we have next. And this is an example of wordless instructions. Now, this is the PolyMedco single sample FIT kit that many people use. The ones that come from the manufacturer often have a lot of words and may be hard for people to understand. But if you can reduce it down to a single page like this and kind of go over it with the patients, at least especially the ones who have never done it before, that can really help. So these things are on our website as well. And most of them are in formats that could be modified if you have something different. Or if you can certainly, if you're using a different type of test, you can certainly take those instructions and simplify them in this type of way. Next slide. So don't forget about the costs. I know that because it is a cost proposition. Some places get the FIT kits for free from their health departments, and it's easy to hand them out, and it doesn't really seem to cost anything, but some people have to pay for them. The main components are the program materials, the staffing, and then, of course, the follow-up colonoscopy can be very expensive depending on, or hard to access depending on your local situation. You do need to need your own local business case. Oftentimes, you can negotiate rates with FIT companies whereby they charge you for example, if you're mailing them out to people, you may be able to negotiate something where the kits come to you for free and you can send out as many as you want, but they charge you for the developer. And that way, you don't have to worry quite so much about, and handing out this $10 FIT kit or whatever it is. And what if they don't return it? That's a lost investment for the clinic. But if it's free and you're just paying $10 your clinic just is investing the $10 at the time of the developing, then you don't care so much if your return rate is not. I mean, you care if it's only a 50% return rate, but you don't care quite so much because it's not going to bankrupt your clinic. And then you can bill for that. Usually, if they have Medicaid, you can certainly bill for that, and it will cover the cost. And Medicare definitely will cover the cost, actually, for more than the cost of materials. Next slide, please. So I just want to let you know this is a resource for you. This is our website, FluFIT.org. We've recently revised it. It looks a little bit nicer and has some updated materials that hopefully you'll find useful. Next slide. So, and then just in summary, they're just one of many ways to kickstart or enhance your colorectal cancer screening activities. They reinforce this message that just like a flu shot, we need to offer FIT to our patients every year. The lessons learned can be used to improve screening practices throughout your organization. Next slide. And then keys to success are, again, deciding that it's important, engaging the whole clinic team, make it feasible, make it fit into people's workflows, make it fun and creative, map out effective processes. And by that, I mean really even just very simple things like the sequence of you give the FIT kit before the flu shot or after the flu shot. That can have a big impact. At Kaiser, the first time, there's one facility that just had a terrible time getting anyone to accept a FIT kit, and they realized that it was because patients are used to getting their flu shots and leaving, and they had this table off to the side where they were handing out the FIT kits, and no one wanted to go over there. So what they did was they just said, well, we're going to give them their FIT kit before they can have their flu shot. We're going to force that issue and insert it in there. And then suddenly it became very successful and easy to do. So you have to think about your processes, try not to give patients the choice to hear about and have the opportunity to get FIT testing if you're incorporating the process in a way that it's really embedded to work. And invest as much thought and time into that as you do with your flu shot. Learn from your mistakes, and don't expect to be 100% successful with, don't have such high ambitions that you think that if you don't get, doesn't work perfectly the first time that it's a failure. It's actually, if you get just a few people screened, that's actually a small success that you can celebrate and probably build on. I just want to let you know we do have a Facebook page which we're trying to develop, and so if any of you have successes, you can look at FluFIT.org on Facebook and share your stories. And as I said, don't give up. Whatever you decide to do for colorectal cancer screening, if you're paying attention to it, you're investing time and energy into it, I'm sure that your screening rates will improve as they have been, and that ultimately we will see screening rates of 80% or more in community health centers, and that would be certainly something really to celebrate. I don't know if do I have any other slides? So these are just the available resources that I already mentioned. And again, I think the American Cancer Society has been a tremendous resource for assisting clinics, and so certainly please do work with them. Sometimes they can either give you advice or come out to your clinic and check out the roundtable for other resources. And I'm sorry, I guess we started a little late and I'm a little bit long-winded. Hopefully we'll have time for the rest of the presentations and some discussion. These are just some of our partners in this work, funders and so forth. And I think that's it. Is there one more slide? That's it. Thank you very much. I hope this has been useful.
Thank you, Dr. Potter, for that great information and your motivation. I see we have some questions coming in, and we'll get to those shortly at the end of our presentations. Dr. Potter mentioned some resources on the FluFIT website, and I wanted to also mention an additional resource. There's a powerful patient story. The South Dakota Department of Health developed a short FIT patient testimonial, a Bonnie story, something that can be shown to patients or at a staff meeting with clinicians. So we wanted to just include that, and we'll send a link to that patient testimonial video after the call. Next, I'd like to introduce Mallory Cosell. Mallory, you can hit *1 to come off mute. Mallory is going to be providing an example from her experience with the FluFIT event from last year. Mallory is a director of quality at Stanford Health, and she has a passion for population health and cancer prevention and currently manages the prevention screening projects for Stanford Health System. Mallory, are you there?
I am here. Can you hear me okay?
Yes, we can.
Wonderful. Well, thanks for having me today. I'm going to talk about two FluFIT programs that we implemented last year and some lessons learned. I know some of our friends from Bismarck are on too, so Stacy or anything else from there, if you're on, feel free to chime in and provide more information related to the work in Bismarck as well. But Sanford's a large integrated healthcare system that spans the Dakotas, northern Minnesota, and into Iowa. We have 4 hubs, 4 tertiary medical centers, 2 of which are big teaching hospitals. So we cover a lot of geographical area and serve a wide range of populations across the system. And so we've embarked recently on our FluFIT journey. Last year was our first year. We tried in 2 different areas. We had 2 pilots, one in Fargo and one in Bismarck. And a lot of lessons learned for both of them. We had a little bit of success. We did hand out a few, and when I say a few, I mean 6 FIT kits, so more than 0, but had some lessons learned. And so I'm just going to talk a little bit about some of the barriers we face in some of our strategies for this upcoming year. Dr. Potter actually touched on one of them, which was the location of where we were handing out the FIT tests at a blitz, and I'll go into that in a little bit more detail here. So we did host 1 pilot in Fargo. We have large flu blitzes within the Fargo area. Each year where hundreds and thousands of patients actually come through and wait in line upwards of an hour sometimes for a flu shot. So we thought that was a really good opportunity to reach a lot of people. Again, kind of the same opportunity that Dr. Potter saw at Kaiser with some of their flu blitzes. And so we worked to set up a FluFIT station or a FIT station, excuse me, at our flu blitz, and had planned to be there at the beginning when people were waiting in line and use that as our opportunity to evaluate or have them fill out a little survey to see if they were eligible. And then for those that were eligible, we would go through the process, order the test, and then make sure they got it. And one of the things was the location, and actually a barrier that we didn't quite plan for. It was a little bit unexpected, and we think it, really did impact our opportunity to hand out tests because the location of the label printer for our FIT test. So we needed to provide a patient label on the FIT test before we handed them out, and the location of the printer ended up kind of being back in a corner. So we ended up being kind of pushed back. And the booth then was after patients had their flu shot. So exactly the same scenario that Dr. Potter mentioned is after patients had waited in line, again, upwards of an hour for a flu shot, a lot of patients weren't interested in stopping to discuss colorectal cancer screening after. So that was a lesson learned in just talking about the location of having that conversation, doing it at the beginning while they're waiting in line, and kind of reevaluating how we could do a better job with that. Many of the patients, too, that did fill out the survey were already on the colonoscopy route for screening, which was great, so up to date with screening. So also looking to how we do a better job of integrating the FluFIT work into our primary care clinics where we have walk-in and scheduled flu visits throughout the season. So where's our opportunity when patients are coming into the clinic every day rather than just at our flu blitzes as well. So that was one of them. I hope that made sense. And again, I'm open to questions at the end of this as well. The second FluFIT program that we trialed was in one of our primary care locations in Bismarck. And they actually did do it in conjunction with their walk-in or scheduled flu shots at a single clinic. They handed out 4 FIT kits. 2 were returned. One of them was positive, and one of the patients ended up with a follow-up colonoscopy. And so, again, we did end up getting, 4 patients screened is 4 patients screened in a short amount of time. So we certainly still consider that a success, but recognize that we have a lot of opportunity to improve. Barriers that we recognized in that pilot was that when we are doing flu shots within the clinic, we use a separate visit type within our electronic medical records. We use a flu visit type, and within that visit type, we don't have orders to place. So initially when this visit type was created, it was for efficiency. It's short and fast for our nurses to go quickly through the flu visits, but when we talk about ordering a FIT test, they then have to close that visit encounter, open up an orders only encounter, and then order the flu shot. So in terms of workflow and efficiency, that was definitely a barrier and something we're talking about at the system level. How do we make that a little bit more efficient so we can provide care at the flu shots related to colorectal cancer screening as well. So opportunities for next year, things we're continuing to work on is looking at ways to streamline the workflows within the clinics, including our electronic medical record workflows. Absolutely want to partner more closely with employee health. As I mentioned, we're a large healthcare system. We have over 27,000 employees, so to ensure that each of them are up to date would certainly help us out as a system as well. So how do we partner with our employee health friends to make sure we're screening our own Stanford family, and then also, if we do this at a flu blitz again, making sure we plan for printer location and where we're going to be at to have those conversations with patients along the way. So a lot of opportunity to do better in the future, but as Dr. Potter kind of mentioned, we gave it a try and certainly don't consider it a failure. We are going to learn and move forward this next year. Are there any questions I can answer right away, or do we want to wait for those at the end? Stacy, also?
Thanks, Mallory. I think we're just going to, we've got one more speaker here, and then we'll get started with the questions.
Perfect.
Thank you.
Thank you. Yep.
Yeah, next I'd like to introduce Jackie Arpan, and Jackie, you can hit *1 to come off mute. Jackie's a public health educator, and Brenda Mills, also a community health nurse from Indian Health Service Sioux Sands Hospital. Jackie, are you there?
Yes, I am here. Brenda had to leave. Can you hear me? Hello?
Yep, we can hear you, Jackie.
All right. I was waiting for something to flash. Okay. I want to tell you about a little bit about our program. We are in Rapid City. We have approximately 20,000 active users in our system. This is our second year that we're participating in this grant to increase the GIPRA rates on colorectal cancer screening. The first year we did 150 for the first timers, and this year we did 150. And the CHRs took half, 75. They have about 10 employees. Public health nursing, we took 75, and we have 5 employees. And then this year we did what they call like a step down. We did screening again on the ones from last year that didn't have a colonoscopy. We gave them an incentive to do a screening again so that they kind of learn the importance of doing it every year. So we did 75 of those. We increased our GIPRA rates 7.7%. It should go up a little bit more because we didn't hand in everything. We got 13 left, kind of down to the deadline. One of our biggest assets of our team is the networking. We work really well together. We have Kelly Thompson from the lab. We have the outpatient nurses that refer the patients and make sure that they get us iFOBT kits. We have the public health nurses that go out and make home visits, and my office, health education, the CHR program. And so we have that benefit of working out in the community and knowing people, so that's one of our pluses. Let me see, making it short, one of our problems that we're having is the cell phone numbers. A lot of them have changed, addresses have changed, so we're running into not finding quite a few of our patients. The nurses were having to start checking the samples because some of them didn't do them correctly or didn't do them at all. Then we had a few problems with the referrals for the colonoscopy. Some of them were out of our service area. Some of them refused to do a colonoscopy, and there was a few that we couldn't get a hold of. Probably one of the things that we would do differently this year, we had our kickoff on Good Friday. We had a health fair, we had an egg hunt, we had that rolling colon. The Tribal Chairman's Health Board brought the rolling colon, and we had a pre- and post-test there. We took names. So if we do it again next year, if it's available, we would probably do our kickoff earlier because we do our flu clinics in October and November. So by the time we started in January, most of the people already had their flu shots. Let's see. I think that's about all. Am I still on?
Yes, you are. Thank you so much for sharing your insight with us today. I think we're going to move into the Q&A
That's all I have.
Webinar.
Yeah, thank you so much, Jackie, and thank you, Mallory and Dr. Potter. We certainly appreciate hearing all of this great information today. We do have about 9 or 10 minutes for some questions, and I see some questions have been coming in. The first one, excuse me, is around somebody wondering if, Dr. Potter, if you would have some thoughts about the benefits of using the FIT test and the iFOBT instead of the old GOYAC stool testing. It sounds like there may be some folks out there who are still using the GOYAC stool testing.
Sure. If that's all you have access to is the GOYAC testing, you know, I understand why some sites would like to continue it. It's maybe a little bit cheaper and people are used to it, but the GOYAC testing requires 3 samples usually, so it takes a little bit more effort from the patient. It often comes with requests to change your diet and change your medications for a few days so you don't get false positives. So they're just much less well accepted by patients than the immunochemical test because the immunochemical test, you can just give it to the patient, as I said, and they can do it that very night. They can go home and have a bowel movement, and they can mail it the next morning. That makes it much easier for you to explain and much easier for the patient to complete. So anything we can do to make this easier for patients is an advance. And the immunochemical test does not interfere with things that you eat and is really specific to blood coming from the colon. Human, you know, that's not going to be false positives because they had a rare hamburger the night before or anything like that. It's specific for human blood. So it really is, if you can do it, you really should go to an immunochemical test. As I said, if you're wondering which one to get, you can look at the Roundtable's resources, and there are some recommendations there.
Great, thank you. The next question is someone wondering how would you recommend working with GI doctors who may be reluctant to support the FluFIT iFOBT efforts?
So I don't know. I mean, I have found that gastroenterologists are actually usually pretty supportive as long as they end up being able to get paid somehow for their colonoscopies that they perform. And, you know, I don't know what the, you know, and in many communities, hospitals have actually donated colonoscopies. I think this comes up most in places where there are a lot of undocumented patients who may have no insurance or no access to insurance, you know, undocumented immigrants who you'd like to screen, and then what are you going to do if it's abnormal? Can you get someone to do the colonoscopy? There are a lot of hospitals that will donate it. You know, you can sometimes develop relationships where they'll donate a couple a month or something like that, which can at least help you get somewhere with those patients. But I think in public health settings, I think, you know, all of the GI societies now endorse FIT as a good option for colorectal cancer screening. So if they're not up to speed on the value of it, then maybe we need to have the American Cancer Society come in and help them with some continuing education to get them up to speed.
That sounds great. The next question we've got here, how do you recommend implementing risk stratification during the FluFIT process, just to ensure, you know, patients are receiving an appropriate test recommendation?
Yeah. So as I said, I usually am assuming that patients are in a primary care relationship, so they should be being somehow assessed for their family history, and it's really the primary care doctor's responsibility to make sure that if they're high risk, that they should be referred at that level for colonoscopy. But if you are going to, and then, you know, for example, if they already have colon cancer, then they've obviously already had the colonoscopy because, you know, they don't need a FIT test. So I guess there are protocols. I mean, you have to, and I can talk with anyone individually if they wanted to augment that beyond just finding out if they have a colonoscopy or in the last 10 years or a FIT. I can certainly talk with them, but you might want to add a question like, have you had any recent rectal bleeding? You might want to add a question about, and that's probably the most, and do you have a first-degree relative with a family history of colon cancer, you know, under the age of 60? Those would probably be the two other questions I might add about bleeding and then family history. It might slow things down a bit. It might, but those might be questions worth asking. At Kaiser, they don't ask that. They just look in the thing, and if they're due, they send it. Because it's the same, and it's the same thing that they do when they mail them out to people. They don't call the person first and say, well, if you're having bleeding, I don't want to mail you a FIT kit. They just mail them a FIT kit on their birthday, for example. They're due. So because they leave those other higher levels assessments to the primary care physician. And so they think of it more as a public health intervention to get as many people screened with something as possible. I don't know if that answers your questions, but everyone's got a slightly different opinion about how they want to do that based on your level of comfort with what your population needs.
Sure. No, that's really helpful. Thank you. I think we've only got a couple minutes left here, so I think I'm going to turn it over to Jill to close us out here for today.
Yeah, thank you. I want to thank you to Dr. Potter, Mallory, and Jackie for presenting today. We'll be sending all the participants that registered or provided us an email address, the webinar recording, along with an evaluation. So please make sure to register. There are 2 more remaining webinars scheduled for July 20th and August 3rd. And we'll be sending information on those out to you as well. So thanks again for joining, and have a great day. Thanks, everyone.
Thank you.
Thank you.